This conversation is part of our broader series examining how we move from cardiovascular risk screening to meaningful treatment and improve cardiovascular outcomes. I'm pleased today to have Dr. Andreas Kalogeropoulos, a clinical and outcomes researcher in cardiovascular medicine at Stony Brook University, joining us for this conversation. Dr. Kalogeropoulos has expertise in heart failure, echocardiography, and research methodology. Dr. Kalogeropoulos, please tell us a little more about yourself and your background.
Well, thank you for having me. I'm a clinician researcher with a focus on heart failure research, and I have long worked on projects trying to assess what are the risk factors for heart failure at the community level and population health level. And I've also worked on identifying biomarkers that predict heart failure risk, assess what drives adverse outcomes in patients with heart failures at various stages, and understand the epidemiology of the growing prevalence of heart failure in our aging population.
Terrific. Sounds like we're going to learn a lot from you. So let's just begin here. While we've made significant advances in identifying cardiovascular risk, there's still major gaps between screening and treatment initiation, as well as long-term management. So we're looking forward to exploring that challenge from a systems and a policy perspective. Dr. Kalogeropoulos, from your perspective as a researcher and clinician, how would you characterize the current gap between cardiovascular screening, risk factor screening, and effective treatment?
I think that we are using like a 20th century healthcare delivery model to apply 21st century science, if I were to describe this in a nutshell, in the sense that there is a real gap in translation of tremendous discoveries, like the amount of discoveries is tremendous, but we're not following up with implementation. So there is a substantial translation gap. And if I were like to identify the three main issues that lead to this implementation gap, that is like an aging population with increasing disease complexity that is not fully appreciated like at the policy and the practice level. We have a system that has misaligned incentives in terms of what is actually incentivized and what we're trying to do at the level of prevention and population health. And also, there are substantial inequities in multiple terms, like in education, access, income, that compound the implementation gap.
All right, so the rise or expansion of the aging population, the aging of the population, incentives, and inequities. Is that a fair summary?
Yes.
Yeah.
I think
Okay.
so, yes.
So it seems, well, we have new guidelines for blood pressure management. We have, and for lipid management, as well as prevention and other areas of treatment. We have, I think, good current guidelines for heart failure management. Are those guidelines adequate? Are they up to date? Are they good?
I would say the problem is not the guidelines because the guidelines are based on solid population science. The main problem is implementation of the guidelines. And if I were to break the problems with implementation of the guidelines down, that would be there is like a long way between individual guidelines that mostly still like describe the disease process as linear and actual implementation in a patient with multiple comorbidities with social support issues, with access to care issues. So there is a gap here between like describing the disease process in the guidelines and what actually happens with the patient. And unless we incentivize like more discussion with the patient and individualization, this gap will persist because you cannot take a linear disease process from the guidelines and apply it like ditto to the individual patient. So the important part is the connection with the patient, understanding the individual issues, and try to apply the guidelines, keeping those nuances in mind. And this has somehow to be tied into the system and eventually incentivize the outcome, which is adequate prevention, adequate control of risk factors. And this is when you will have results, I believe.
Yeah, I'm hearing you, excuse me, being very clear about the role of incentives in driving change and in attracting resources and attention to prevention and follow up on identification of risk factors. What what are some of the biggest system level changes that we need to affect? We only have, with roughly half the adult population having hypertension, but only a quarter of those people being treated successfully. How do we change that? What systems changes need to take place? And from the inside, your perspective, how would you incentivize those changes?
I think that what evidence has shown that if you incentivize a certain process, a certain outcome, then you will have the process and you will have the outcome. Like we know that from the field of heart failure, and that can go both ways. If you incentivize the wrong thing, you can get more of the wrong thing also. But I think that teams that anchor to primary care and team-based management is important, is key to prevention, and should be incentivized by uh, by providing financial incentives to keep the individual patient in control in terms of their risk factors, keep the patient engaged with the healthcare system, and also in the long term, incentivize better long term outcomes. So I think we should encourage the systems to quote unquote marry the patient and for the marriage to be happy. So, which is misaligned with the current uh, financial incentives because we are still incentivizing visits and procedures, and that creates a tension between, for example, personalized care, which is important, uh, prevention in the context of patients with frailty and multiple comorbidities, and and the and the and the fact that the healthcare system are trying to increase volume to maintain financial viability. So there's a tension here, and this may require, in fact, a new deal, a new social contract, because we have an aging population. Like every clinician you ask, they will tell you that the patients they are seeing today are more complex than the patients they were seeing five years ago. I'm not talking about 15 years ago. I'm talking 5 years ago, because there are new medications for every disease. There is fortunately like increased uh, survival for every difficult disease process, heart disease, cancer, anything. So which increases the pool of patients who need the care uh, while having multiple comorbid conditions, taking complex therapies. So physicians need to keep up, need to spend more time with the patient, and they need to understand where the new medication fits, like in the armamentarium of other medications for other processes. And that requires time. So that's why I'm saying you cannot keep doing what you were doing in the 20th century with the science of the 21st century.
Yeah.
So that will
Yeah.
require a new social contract.
Yeah, so you've just talked about physician care, where they need to spend time and the constraints on their time. Where does team-based care fit in here, or does it?
Uh, It absolutely does because it has been shown time and again that if you integrate nurses, pharmacists, and other healthcare professionals, especially in primary care and risk factor control, you get great results. And this is an important tension that I wanted to mention. We talk about personalized medicine. Well, personalized medicine is not about like personalizing the molecule, it's about understanding the individual patient. So it's slightly different because we tend to think about genomics and metabolomics and new markers. No, personalized medicine is mostly about understanding the full context of the individual patient, and this is where teamwork can help a lot.
That point really deserves to be underscored. So, personalized medicine, in your view, is not only about someone's genome, about someone's biomedical factors and measures, but also, and I think I heard you say more importantly, about the context in which they're living, they're learning, they're working, they're praying,
Yes,
playing, they're living their daily lives and making the everyday decisions that really affect their health. Is that
yes.
correct?
Yes, and that takes time to connect with the patient, understand the patient, and many, many times try to find workarounds that fit their lifestyle and constraints. And that requires time and connection. And that has to be incentivized.
So, what's the role of the physician and of other team members in bringing all that together to set the patient up on a course for success?
I think having a primary care physician who can put together all this angle is of paramount importance. Having someone who can bring together the various problems that the patient faces, like both from a medical slash disease perspective and other social stressors, for example, and distribute the resources as needed in the sense provide the right consultation or send the patient to the right consultants, and also understand like the context of other comorbid conditions. So it is like the primary care physician should be the center of preventive care by bringing together like other experts and also distribute like the workload for follow-up and whatnot to other healthcare professionals. I think this is a reasonable and workable approach.
Okay. And are there situations where that's hard to do? Say in physician deserts, whether they're in urban settings or rural settings where it's an hour and a half drive to get to a primary care physician. Uh, how do people in those situations, how do they manage? How can we help them to be successful in identifying and managing cardiovascular, cardiometabolic risk factors?
I think that this is where technology may really help. Now, you cannot force physicians like into areas, but you can bring their expertise anywhere with available technology. And technology can work both ways. Like currently, we have good equipment that can transfer information from the patient's home to the physician, and the physician can take this data and make decisions and help the patient, especially in preventing care from anywhere. Again, if we incentivize this kind of care, which is not a substitute like for in-person visits, but it can help. If we incentivize that kind of care, I think we will be in a better place in a few years. And speaking of technology, and that includes AI, can help you keep doing more of the same wrong thing, or can help you do something different. So it's upon us to decide whether we're trying to use a new technology to do all things more efficiently towards the right direction, or we're changing the direction altogether by implementing newer models of care using the new technology.
I'm so glad you brought that up, that distinction between technology helping you continue to do things that are unhelpful versus helping you do things that are beneficial. And it's very important that we manage the use of technology so that we're deploying it in ways that are helpful.
Yes, you may use, for example, let me bring an example. You may
Yep,
use
I was just going to ask
AI,
you.
you
Yeah.
may use AI to justify, for example, procedures, and then insurance companies will use AI to fight back your claims. So we're wasting a lot of AI firepower, which has a cost that the society cannot see yet, but using AI does has a cost, like actual cost, environmental cost, and whatnot. So we may use like AI this way, which is obviously inefficient from a society perspective, or we can use AI, for example, to pick the patients that need to follow up proactively because
Mhm.
it's unlikely that they're going to follow up themselves. Just bringing up an example, like find new models of care
Yes.
instead of trying to use use AI for the old model of care and providing no actual results.
Yeah, that makes a lot of sense. Andreas, you've times about incentives. How do current policies and payment structures and the incentives that they create, how do those hinder cardiovascular prevention?
Well, I think the current misalignment between incentives and the financial incentives and outcomes in terms of cardiovascular care prevention is mainly the fact that healthcare systems are still paid for visits and procedures, especially procedures. I'm Associate Program Director for the Cardiology Fellowship Program at Stony Brook. Without saying that interventional cardiology or electrophysiology are not interesting subspecialties, like 5 out of our 6 fellows every year want to go into interventional cardiology or electrophysiology. Heart failure, which is a less procedure-oriented subspecialty, has already gaps in 50% of centers in the country, and we're talking about like world-class centers. But their spots are empty. Let me take it to the next level also. Infectious disease has 40% spots empty for training nationwide because there are no procedures involved. So what I'm saying, we are not incentivizing physicians to be trained in specialties and subspecialties that don't include procedures. And not everyone is chooses to train in specialty A or subspecialty B because of financial reasons, but I think that plays like a major role. And because the system still incentivizes procedures, no matter how we talk about value in care, this shows also in the focus of the individual healthcare systems that we're trying to perfect like the, the screening, eligibility, and implementation system for procedures, but focusing on primary care is kind of a secondary thought, for example. So the more integration we have of primary care and outcomes of primary care, like risk factor control, long-term outcomes, the more you incentivize that, the more change you will see. But you have to incentivize like seriously. In the sense, if you keep doing the same thing slightly differently, you won't see change for the next 10, 20 years. That's
Yeah.
where the misalignment comes.
Okay. Yeah. And So I appreciate your tying that back to your earlier comment about misaligned incentives. I tend trying to perhaps be a little more stark about it. I tend to talk in terms of perverse incentives. Uh, so along those lines, uh, I mean, you and I know, and probably everybody who's listening to our conversation knows that it's not only in the patient's best interest for their health and well-being, but it's also the most cost-effective for society to identify early on when someone has elevated LDL-C or now we're going to be able to identify and then treat LP little a, or in your specialty of heart failure, if we can intervene early on to help people control their blood pressure from early in life, then that helps them prevent heart failure and not need the interventions. But is it the case that a system actually makes more money when they wait to treat somebody than they do by preventing the need for acute or intensive treatment?
So it is absolutely true that the most cost-effective approach to care is focusing on primary prevention, because then you end up in the final years of the life of a patient pay a tremendous amount of money just trying to keep the patient alive with reasonable quality of life, which wouldn't be the case if we were to spend more, like focus more on the earlier stages of disease, during which you have to pay much less to prevent more advanced disease. So, if without being technical, it is much more cost effective to focus on stage A disease, meaning just risk factors, or stage B disease, meaning there is some damage to the heart, but with appropriate medications and lifestyle changes, you can stop it there before it becomes manifest, before the patient has symptoms. So that's the most effective uh, mode of care. But I would like to add one more thing. Like I previously talked about a new deal, a new societal contract, and I think this is something that it's not communicated adequately by political and healthcare leaders. What I mentioned about the rapidly increasing prevalence of diseases that were previously lethal, because with so many developments in science that prevent patients from dying, which is great, but this increases the pool of patients who need specialized care. So the cost of healthcare with AI or without AI will continue to increase, and will increase disproportionately to the increase of the population. So this is something that needs to be discussed, and you won't hear about it anywhere, but it's unlikely that with the same healthcare system capacity that we had like 10 or 20 years ago, we'll be able to sustain the same level of healthcare. And this is true for private uh, private incentives healthcare systems versus public healthcare systems. You can look like what is happening, for example, in the UK, in Canada, in Germany, in the US. So these are systems that range from almost 100% public health to almost 100% private incentives healthcare delivery. In the sense, I'm using the term private in the sense that if an institution is independent financially, it has to survive as a business, right? So even so that applies even to fully publicly funded systems, to fully individual businesses. So this needs a new societal contract, and you won't hear people talking about this, but with the current trends, the current level of healthcare, it's not sustainable.
Yeah. Yeah. And we we sometimes the wrong pocket problem, where, as you said, it's very cost effective, clearly more cost effective at the societal level, at the macro level, to treat, but that doesn't mean that that same economic logic applies to a healthcare delivery system. For them, it may be more economically beneficial to treat. So we need, I think that's going back to what you were calling earlier, the misalignment of incentives. We need to
And
change those.
I totally agree. And in fact, one pathway to sustainability is focusing on primary care and prevention. That's a major path to sustainability. Because think about it, if we fail in prevention of cardiovascular disease, then you will need more specialists for the aging population who will live with new devices, disease states that are sustained with new medications, but they need follow up with new imaging, and you will need more specialized workforce to keep up with that. I think this is less sustainable than focusing on primary prevention, control of risk factors, and having less advanced disease. And that applies to every healthcare system. Primarily, like in healthcare systems where we put a lot of value in personalized care. Because
Yes.
now we are expecting personalized care, which means we are expecting more from the healthcare system. And that's why
Yes.
focus on prevention is a more sustainable pathway.
So, Dr. Kalogeropoulos, I read the commentary that you and our National Forum board member, Javed Butler, published in the Journal of the American College of Cardiology recently, in which you forecasted a a growing shortage of clinicians, specifically of physicians. And it looks like over time, looking out to 2060, that just gets worse. So, given that shortage, and given what you've said about team-based care, if you were the president or the secretary of health for a day, what change or changes would you make to enable us to take fuller advantage of other types of clinicians, of nurses and PAs and pharmacists, and so forth, so that we can close those care delivery gaps and achieve some of the cost savings that you were talking about?
I would push hard for serious investment in primary care infrastructure and team-based management of the patient. I think if I had like to put something as number one of my budget line, I would put that serious investment in primary care and team-based management of the patient.
All right. That's very clear. I appreciate that. One thing we haven't talked about yet that I wonder if it's possibly a solution to this gap that we face between diagnosis of um, cardiometabolic risk factors and management of them, and that's shared decision making. What's your experience with shared decision making? And as a researcher, what's your understanding of the evidence around it? Are we taking optimal advantage in today's system of shared decision making?
So I am a little bit heretic when it comes to shared decision making because I think that the healthcare professional needs to help the patient substantially to make decisions, especially decisions that rely on a lot of complex science that the patient may not be able like to comprehend. So my rule of thumb is for therapies that are not life changing for the patient. For example, we're not talking about implanting a device that will change the life of the patient because they have to live differently afterwards. But when it comes to administering like medication A or B for blood pressure, I think the physician should help the patient substantially, make the decisions, provide the evidence in a way that the patient can understand, and really guide the patient and help with implementation, like push to that direction. Not because I think the physician should be prescriptive, but because I believe it is unfair to expect from our patients like to understand the nuances of the background science. So until a certain point, I truly believe that the patient needs guidance and help with implementation. And I would leave the shared decision making only for decisions that are truly life changing. For example, if we were to administer anticoagulation to a patient and they need like to be careful and measuring their blood thinning medications frequently and whatnot, then this is something we need like to discuss fairly and openly with the patient and simplify the pros and cons. But I wouldn't go into lengthy discussion whether like an ACE inhibitor or angiotensin receptor blocker is a better option. I would just recommend what I think is best based on existing science and keep things simple and accessible to the patient. Just to give you a
Hmm.
construct and
Sure,
contrasting example. And obviously,
sure.
when it comes to procedure, well, this is where serious third decision making comes in.
Yes, that makes sense. Um, so is there a role for the electronic health record to help patients A, come to encounters with clinicians prepared to receive information, ask questions, and also in follow-up to understand their condition, their choices, and the rationale behind their course of treatment?
This is a great question, and this is where AI can truly help change the model of care because we could really prepare the patient with a set of questions that are accessible for their education level. And we could also help the clinicians understand what are the challenges and focus on the challenges. So it can be bi-directional, and I think it's very doable even with the current technology. The barriers come from issues of security and confidentiality, which is an important component of integrating AI into the medical record as you give access both to the data and the ability to communicate with the patient. But besides those challenges that are actively being like worked on, I think this is a great tool that we could use, and it's a great avenue to bridge the gap, the implementation gap, by providing the patient with guidance for us to get more information from the patient and also select the patients that need more help with implementation. Instead of using a blanket approach or a checklist for everyone, I think this would be a much more time effective approach.
Okay, that's very helpful. We appreciate your perspective. So we've just talked some about the role of technology in improving care and improving prevention, strengthening prevention. What about the new biomedical innovations that are bringing us new tools to help patients and their clinicians manage their LDL cholesterol, manage LP little a, or people who've had blood pressure that they haven't been able to control with existing technologies, existing therapies. Now there are new arrows in the quiver or coming shortly. So, um, do those give you hope? Do you see opportunities for us as a system at large to take greater and more full advantage of those innovations?
I think there's a lot of potential, but we have to be mindful also of the technology gap in the sense that the patients who are more likely to follow up more closely and engage more with the healthcare system are the ones that are more likely to use newer technologies to track and manage their risk factors. So to address the implementation gap that we have been discussing, we need to think of ways to reach out to the patients that are less engaged with the healthcare system. And this is where new technologies can help, but this needs like proactive work to reach out to those patients. So I think the simpler the technology, usually the better it works, because the more sophisticated technologies cater to patients who already have a level of education that allows them to access these technologies and be closer to the healthcare system and be more engaged anyways. So you see so you see here like the misalignment also that with the between the potential and the and the gap. So we need to think of ways to engage the patients who are less likely to be engaged, and this comes down to uh, proactively uh, trying to engage patients who are less likely to engage with the healthcare system, using more accessible technologies, less sophisticated, easier to use, and more automation always helps. Like the less human intervention something it takes, the more likely it is to be more easily implemented. Although I know this sounds like less personalized, but it tends to work better. That's my take.
Yeah. So let me see if I can paraphrase and tell me if I'm getting this accurately or not. You're actually tying the emergence of technologies, of new technologies, to what you talked about at the outset of our conversation, and that is these disparities in health and in care access and access to the vital conditions for health and well-being. So you're saying, I believe, that technology offers, on the one hand, the risk of making those disparities even larger, or on the other hand, it could be part of the solution to help close those gaps. Is that accurate?
It is. And in fact, the natural experiment about this came during the COVID era because
Hmm.
we had to use televisits. And if you look at the data, the patients who, like older patients, less educated uh, patients, more disabled patients, were less likely to do video visits versus just phone visits, or less likely to do televisits altogether. So
Yes.
it was a natural experiment that taught us a lot about using technology in healthcare in a way that was forced, but also like provided us with a lot of data. So to summarize, I think that we need to use the newer technologies like sensors, home-based systems more proactively and try to reach out to the patients that are more disadvantaged in terms of their ability to use the technology or understand the technology. Reach out to them, make the technology simpler. Like try to find out the best way that they will engage with the technology that will give us information, and then this information translates back into better control of risk factors. And there are many emerging technologies also that are coming up, but again, the focus should be on implementation where it is most needed.
Absolutely. Yeah. Thank you for making that abundantly clear. What, two more questions. What about trends that you see that we're experiencing today? What gives you hope for a brighter, healthier future and for closing those disparities?
So I think that uh, artificial intelligence has a lot of potential of providing the right information. Now we are still in the infancy era of AI. So there is a lot of information and misinformation coming from AI because, for good or for bad, AI is replacing the old model of internet research that many people are doing today to find out about the risk factors or conditions and whatnot. So as the technology matures and will be able to provide more accurate and more evidence-based information to the individual, I'm very hopeful that this will help people get on the right track and understand more and engage more and better with their risk factors. So which was previously was like a little bit more chaotic. I know it sounds like weird, like wouldn't getting information from reliable websites be better than having AI summarize information? Well, not necessarily, because you know each one of us would seek information in different places. So if you have like uh, better summarized information from reliable sources, from responsible AI, which is an important, which is another topic of discussion, that could help a large majority of patients understand more and better about their condition at a level that is accessible for their background education and whatnot. So I'm very hopeful that AI will help keep the individual better informed in the long term. As I mentioned, it is still in its infancy, but I think the technology is improving fast, and there is no shortage of funds being invested in the technology. So I think that we will reach like a place where, for the most part, the individual will be able to get reliable information at their level of access, and that will help a lot. So that's one trend that I think will work for us in a positive direction.
All right. Thank you. And final question, we've talked a lot about misaligned or perverse incentives. What would be the first change you would make to bring those incentives for healthcare delivery, for patient decisions, patient choices into alignment with prevention?
So I think incentivizing long-term engagement of the patient with the system, like keeping the patient consistently following up, would be one important incentive, and then provide additional incentives for proper control of risk factors, and at a second stage, long-term cardiovascular outcomes, if we're talking specifically about cardiovascular and cardiorenal cardiometabolic risk prevention. So having a multi-layer system of incentives that rewards the systems of keeping the patients engaged, keeping the risk factors in control, and down the road having measurably better outcomes.
That's a great note to close on. Andreas Kalogeropoulos, I love your beautiful background at Stony Brook there, and I'm grateful to you for joining us for this conversation today and to share your insights and pearls of wisdom from your clinical experience as well as your research.
Thank you very much for having me. It was a pleasure.